Hello, everybody. I'd like to welcome you all to the second installment of our webinar series covering acute stroke during the American Stroke Month. I'm Joe Marion. I'm the chair of the Neuroservice Line on the SIR-RFS. I'd like to remind you all to sign up for the upcoming webinars as well. There'll be more information coming out about that. And also, anytime during our presentation tonight, if you have a question, there's a question box where you can type your question in on the right-hand side of the screen. And then at the end of the presentation, we'll go through those questions. I'd like to introduce Kevin Carr. He's a member of the Neuroservice Line and also an R1 at Aventura in Florida. And he will be introducing our presenter. Go ahead, Kevin.
Hi, good night, everybody. Good night to our friends on the East Coast and to our friends on the West Coast. Good evening. I'm here to present Dr. Yafelle Serulle. He holds an MD degree from the Universidad Nacional Pedro Enrique Sirena and his PhD as well as postdoctoral training at the New York University School of Medicine. He went on to fellow at the University of Maryland Medical Center, where he completed diagnostic and clinical interventional fellowships in neuroradiology. Dr. Serulle currently serves as a neurointerventional radiologist and director of stroke here at Aventura Hospital and Medical Center, as well as Westside Regional Hospital here in Plantation, Florida, where it's been for almost 2 years. So without further ado, our presenter tonight, Dr. Yafelle Serulle.
Okay, thanks, Kevin, and thanks everyone for having me here. And today I'll be talking about something very exciting, I guess, for everyone here, which is stroke. Specifically, I'll be talking about imaging and diagnosis of acute stroke. And I'll proceed with the presentation. No, nothing to disclose that is relevant to this presentation. And then, what I plan on doing was go a little bit, through the background, of a stroke, and kind of like talk about how, what got us to where we are. As many of you know, we are in very exciting times in a stroke. And I kind of like wanted to bring us all up to the same page where we are currently in a stroke and why imaging plays such a, an important role in triaging, these patients. Then, I'm going to talk about relative to that, I'm going to talk about, the recent trials, and hopefully many of you are aware of them. And if not, I'll try to kind of like summarize them and kind of like underline the importance of these trials and the implications that these trials have in the way we manage and, and triage, a stroke. And then I'll go through, each one of the imaging modalities that we're currently, using. And then I'll go through some case examples and kind of like focusing on the importance of these imaging modalities and how, how in each case we can use different modalities to sort of like work our way into understanding what is, going on with every specific patient. So as an introduction, when we talk about a stroke, obviously we know it is a broad term that refers to both hemorrhagic and ischemic, with ischemic stroke being the most common of these two. 87% of cases people talk about that is ischemic, and for the purpose of this talk, every time we talk about a stroke, we'll be referring to ischemic stroke, and we know that it results from an obstruction of an artery that's supplying blood to a part of the brain, which various causes, with big ones being athero and cardiac arrhythmias, and then less common causes like arterial dissection and coagulation abnormalities. But the bottom line with a stroke is the concept that, neurons can begin to die immediately after they are deprived of blood. And I think that's a concept extremely important in a stroke. Time is brain. And the second most important thing that I want to point out on this slide is the fact that the field of a stroke has seen very dramatic changes since the most recent trials were published starting in 2015 that really revolutionized the field of a stroke, propelled the field forward. 2015 being a big year for about 4 randomized controlled trials that came out. And I think I saw in the series of these talks that you have one at least lecture focused on them, which is very important. And more even recent trials from this year, even starting in January of this year, that we saw another big trial that came out. And I'm gonna briefly talk about these trials and how they, have a big implication in how we treat a stroke. An important thing to kind of understanding a stroke nowadays is to kind of like understand the difference between a small vessel occlusion and large vessel occlusion. When we refer about a small vessel occlusion in the brain, we refer to smaller branches in which a small clot can occlude, and therefore, when you occlude a small branch, you have a smaller stroke. And then that is very different to when we talk about large vessel occlusion or emergent large vessel occlusion, ELVO, which means that you have an occlusion involving either the internal carotid artery or the M1 segment of the middle cerebral artery, which, either of which is going to cause a very sizable stroke that therefore can lead, to significant disability. So remember the concepts of ELVO versus, a small vessel occlusion. And at the brain tissue level, what happens in a stroke is that immediately you get an occluded vessel, in particular a large vessel that's occluded, you're going to get an area of tissue that's going to die immediately. That's going to be the core of the infarct. That's the area of severe ischemia where the neurons are going to undergo very rapid necrosis. And that's, typically not very big initially. And surrounding this area, you're going to have what is called the penumbra, which is the area of moderate ischemia, where the tissue may remain viable for several hours after the occlusion. And that penumbra is indeed the tissue that we are trying to save when we do either thrombectomy or recanalization with IVTPA and so on. The problem with the brain, unlike, other tissues in the body, is that the neurons are very sensitive to time. When there is no blood. In other words, are very sensitive to lack of blood. And as you can see from this graph, the core of the infarct can expand very quickly. And once that happens, as you can see here, the penumbra obviously decreases. So if you are here in this stage already, there's going to be very, very little tissue of the brain that you can save. Whereas if you catch the stroke very early on, like here, you're going to have a large amount of tissue that you can save. So that's the difference between the core of the infarct and the penumbra. And I'm going to talk a little bit about how we can image, those two different tissues. And as I said, a lot of research has been put in understanding how time is brain. And as you can see, every minute every minute that passes since the obstruction of a vessel is equivalent or leads to the death of approximately 2 million neurons, based on some studies, that is equivalent to the brain aging approximately 3 weeks. So as you can see, time is definitely brain. So what are the implications of all the recent endovascular trials, in particular those that came out in 2015? Well, as I said, these trials really revolutionized stroke care. Before 2015, all we could do with patients was give TPA, but after the 15, I think that the concept of interventional therapy became very, very well rooted in stroke, and in fact has become the gold standard of care for large vessel occlusion. In other words, every patient who has a large vessel occlusion should be offered interventional therapy. And as I said, on top of that, all these recent trials have demonstrated the very close relation between fast recanalization and good outcomes. This is a quick summary of 4 of those trials, all of them which were published around 2015. And, we have MR Clean, Escape, Extend IA, and Swift Prime, all of them comparing basically endovascular therapy plus a standard of care versus a standard of care alone. And this is the percentage of increase that you see in the improvement of the modified ranking scale, which is a scale that we use to determine whether someone is independent or not. And this is the percentage increase versus the standard therapy alone, going from 13% more or less in MR Clean all the way to 30% on Extend IA, with the difference in these percentages having to do mostly with the way they selected their patients. But regardless of, in all of these trials, endovascular therapy was superior than a standard therapy alone. And in addition, in ad hoc analysis of all these trials, what has become very clear is that it is, time is brain, as I said, and the longer the time from onset of the stroke to reperfusion, the lower likelihood of good outcome. And this is in fact showing a graph in which we see the functional independence here or the percentage of patients who achieved independence 90 days following the stroke, their relation to the time that it took to recanalize these patients. And as you can see, the quicker the recanalization, the higher the percentage of these patients that went on and had an independent life, meaning had a good outcome. So very important concept. I think that the field, as I said, has changed so much that as late as this year already, we've had two major societies, the AHA and the ASA already, as well as the SNIS, which is the Neurointerventional Society, already putting new guidelines where they are including new time metrics in a stroke, new imaging modalities, and I'll talk about all that, as well as more better guidance into how to triage these patients. So, as I said, some updated guidelines from the American Heart Association and the Stroke Association, some new guidelines by SNIS, and I'll invite all of you in your free time to kind of like browse through those guidelines to become familiar as well with all the stuff that's going on right now. And I think the focus right now is really going into the optimization of systems of care. How do we kind of optimize the care of these patients in terms of what is the appropriate imaging triaging of these patients, what is the right EMS involvement and pre-notification in a stroke, and with the whole objective to kind of get better outcomes on these patients. I'm going to put this slide here because I just want to underscore here the importance of the time metrics and kind of like have an understanding on what are the metrics that our societies, in this case the SNIS, is proposing as benchmark. As you can see, the time that it should take from a patient with an acute stroke coming into your hospital before getting a CT/CTA is literally on arrival. In other words, when you have an acute stroke patient and we get a pre-alert by EMS, we have to be ready to be, receiving this patient in the scanner. These patients are going to be wheeled directly into CT/CTA. The door to CT interpretation, less than 15 minutes from arrival to the hospital, and to CTA interpretation should be, less than 20 minutes from arrival. And then the rest of the time metrics are more related to when to give IVTPA, and in this case, how long should pass between the door or the entry of the patient into the ER and the groin puncture in case the patient is going to intervention. As you can see here, basically you have approximately 60 minutes to puncture that groin. In other words, these are the time metrics simplified. You have 30 minutes before interpreting the CT and the CTA. So after 30 minutes that the patient is in, you should have taken already a decision if you're going to treat or not. And then groin puncture 60 minutes and hopefully recanalization 90 minutes. A few more slides on this trial because I just wanted to talk a little bit about the newer trials this year. And, it's the DAWN trial in which it's been shown, it came out in January, and it's been shown that thrombectomy is not only effective on patients with a stroke less than 6 hours, as it was, in the prior trials, but up to 24 hours in a selected group of patients. And which are those patients are specifically patients who have, who are very symptomatic, meaning with a stroke scale of more than 10, and which have very specific infarct volumes. In the case of those patients who are older than 80 and which have a stroke scales larger than 10, an infarct volume less than 21, as in the younger patients, younger than 80, then they become a little bit more generous with the infarct volume. The way they are measuring the infarct volume is using software to quantitate, the volume of a stroke using mostly CT perfusion, which I will, go through in the following slides. And as you can see, huge difference between patients achieving functional independence in the thrombectomy group for 9% versus the non-thrombectomy group, 13%. Another trial that came this year, the Diffuse 3 trial, in which they use perfusion imaging and a very specific software in perfusion imaging called RAPID, which probably some of you are familiar with, depending on the center. Some centers have it, some others don't have the RAPID software. But this software allows you to automatically quantitate the volume of the stroke tissue and the volume of the penumbra. And it was a randomized control trial as well, multi-center, which was terminated early because of efficacy as well, something which happened as well with the Dawn trial. And as I said, all the imaging component in this trial was done using standardized software. This is an example of the Rapid software. As I said, it's a very nice software. The only downside of this software, and when I say software, it's a software that's attached on your workstation to do all this post-processing. The only downside is the money. It's a little bit on the expensive side. Therefore, some places are a little reluctant to acquire, but as you can see here, the software is telling you the volume of the ischemic core on one side, and then you can see the volume of the perfusion lesion or the penumbra. And based on this mismatch, meaning large penumbra, a small core, you can take the decision to proceed with endovascular treatment. And their conclusion was, of course, that those patients who had a large mismatch between the penumbra and the inferior core achieve much more functional outcome when going through thrombectomy compared to only 17% versus 45% when given medical therapy alone. I think summarizing what I have said so far, I think endovascular mechanical thrombectomy should be offered to every patient with acute stroke and elbow, assuming that the patient, of course, meets the appropriate criteria. And of course, if the patient is a candidate for thrombectomy, every effort must be made to achieve recanalization as quickly as possible. I think selection of patients is extremely important to ensure good outcomes. And that selection of patients is only going to be possible using, of course, your clinical knowledge, but also, and very importantly, the right imaging. And in conjunction with that clinical, presentation of the patient is what's going to allow you to do the right selection of cases and kind of make sure that you can achieve that good outcome that we all want for our patients. So now let's switch gear. I wanted to give those slides as an introduction and kind of like make everyone understand why they focus on a stroke nowadays, and kind of like we're really living in an exciting time for a stroke. I think there hasn't probably been any other time as exciting as this one in the stroke field. Let's talk about now imaging evaluation of a stroke and how we triage, patients in a stroke. And I'm going to start, with the more simple things as the non-contrast head CT, and kind of like go through all the imaging modalities that we use, nowadays for a stroke. Let's start with the most simple study, non-contrast head CT, which I'm sure everyone here is familiar with. Of course, at a very important triage tool, it's going to drive subsequent patient management. Is the single most important study that you need when that patient come in the ER. First of all, it's going to differentiate the type of a stroke. It's going to determine whether it's a hemorrhagic stroke or not. And of course, if it is a hemorrhagic stroke, it's going to be an entirely different management. So that's going to be the first important clue or the first important question that the non-contrast CT is going to answer. It's going to, of course, suggest alternative diagnosis if there's a mass problem mimicking as a stroke, if there are other diseases that could be, being a stroke mimics. It can help evaluate for early ischemic changes, which can be very important in the patient selection. And I'm going to show you some slides, about that. And of course, it can evaluate for complications of a stroke, such as mass effect and hemorrhagic transformation. Let's talk about early ischemic signs first. You have the first common thing that you see in a stroke. You're going to talk about the loss of gray-white differentiation, kind of like a first-year radiology resident knowledge here that you start reading when you start your residency. You can see here the asymmetry in both hemispheres, with the left side of the hemisphere with the gray-white preserved and all the the basal ganglia very well preserved, all the gray matter nuclei, whereas on the right side you have effacement of this gray-white matter differentiation. You're going to look at the insular ribbon sign and that loss of the basal ganglia. You're gonna see effacement of the sulci. As you can see here, the sulci very, very well. You can see them, whereas on this side you don't see them very well. And of course, you're gonna look for the hyperdense vessel sign. Prevalence of early CT signs probably present in more or less 60%, give or take, given given the reviews that we have so far. So not always seen, but sometimes seen, and when you see them, could be very important for the reasons that I'm going to talk about in a moment. And of course, a lot of variability when we look at non-contrast head CTs. Not surprised, radiologists tend to be very subjective when we read studies, and it's inevitable that we're going to be different sometimes when we read these non-contrast head CTs. In this case, we have the classic MCA sign, which means that, there's a dense MCA already with an area of hypoattenuation here, or loss of gray white matter. Very, very likelihood this patient is going to have a thrombus here, and, it's going to be an M1 thrombus right there. And then, areas of hypoattenuation, very important when you're dealing with non-contrast head CT to do the appropriate window. As you can see on the image on the screen on the left, you see kind of like very subtle changes there on the left hemisphere. But when you window and you use very narrow windows, which are very important for a stroke, as narrow as you can, you're gonna this changes in the gray white matter has become a lot more obvious. So always never forget to window your non-contrast head CTs to look for those subtle changes. A very important scoring system that has been used, since few years has been the ASPECT score, which is the Alberta Stroke Program Early CT score. Not so commonly seen in the radiology literature, but very commonly seen in the vascular neurology literature. So most stroke neurologists are going to be very, very familiar with this. And it's a very important tool to use when we are triaging patients and determining whether a patient could benefit from revascularization. It's a quantitative 10-point CT score that are very useful, in particular in those patients with an MCA stroke. And basically what you do, you try to use a segmental assessment of the MCA territory, and in which 10 being the best score, meaning no changes at all. And what you do, you start subtracting 1 point for every of these territories of the MCA. The bottom line is that a lot of research has been done on this, and a lot of the initial research suggested that ASPECT score of 7 or less will predict a worse functional outcome in these patients 3 months after the stroke. What this translated was in a lot of studies suggesting that patients with ASPECT score of below 7 would not be would not have many benefits, in endovascular thrombectomy. So the initial assessment of your CT, you look at your CT, you kind of like look at it and you say, well, the ASPECT score of this patient is 5, which means that, there's a lot of hypoattenuation, which means typically that there's already a large stroke core. Then you would be probably not favoring necessarily revascularization, because at that point you'll probably say that the benefits are not going to be as much, given that the stroke core is so large. That being said, there's been more recent papers that have suggested that ASPECT score between 4 to 7, although not being associated with as many benefits as with those ASPECT scores of more than 7, they still are associated with more benefits when thrombectomy is offered. In other words, thrombectomy works the best when the ASPECT score of 7 or more. It works okay, and it's still better than not providing anything when ASPECT score of when you have 4 to 7, and definitely probably not a very good idea to recanalize when the ASPECT score is less than 4. And here's another, example of how you kind of like count, each number referring to 1 point in that ASPECT's stroke scale or score program. So I'll give you a few examples here. This patient has a right MCA occlusion. As you can see, this patient has a very high ASPECT score. Probably you'll take away 1 point here, maybe 2 points, but this patient clearly, with most of the hemisphere preserved and, most of the, nuclei here preserved. So probably we'll take 2 points here, maybe 1 here, 1 here. This patient has a right MCA occlusion in the context of a high ASPECT score. This patient would be a good candidate for interventional therapy. On the other hand, we have this other, extreme, a patient with a much lower, ASPECT score. You already have a very well-defined wedge-shaped area of hypoattenuation in the left MCA territory, in which you have, a very, low aspect score, probably, 2 or 3 aspect score only, with a very large part of the MCA territory infarcted, probably up to 2/3 in this case. So this patient is not a good candidate for interventional therapy. Moving on from the aspect score to other things that mechanical thrombectomy plays an important role on is looking at, hemorrhagic strokes. This patient had no ischemic stroke, but indeed he had a hemorrhagic stroke, which was mimicking, a right MCA occlusion, because the patient came with sudden, onset of left-sided weakness, except that in this case, the patient had a very large bleed and proceeded, of course, to decompression craniectomy. Important to look at other diagnoses as well. In this case, we have, a patient that came with some right-sided symptoms, no stroke necessarily, but did have an AVM here that you can see here in angiogram. So as I said, a stroke mimics, important to keep in mind. So moving on from non-contrast head CT, now we're going to move on to CT angiography, which is usually the next step that we do after a non-contrast head CT. CT angiography, very importantly, the first thing that's going to answer is it's going to determine the source of an acute ischemic stroke. In other words, it's going to tell you if there's a clot and where that clot is going to be present, and that's going to help you then take the next step in management, which if it's as I said, a large vessel occlusion, the patient's going to probably go to thrombectomy. But not only is the CTA important for determining the source of the ischemic stroke, but it's also going to be important to determine collaterals. Collaterals are very important because we know that patients with good collaterals are or tend to have much better outcomes than patients with poor collaterals. And finally, of course, CTA is going to help you evaluate for alternative diagnosis. Let's take a look at a few examples here. Here we have a patient with right-sided symptoms, and as you can see here, the left, there's a clot there that's starting in the distal M1 segment of the left MCA, extending into the superior and inferior M2 branches of the left MCA. Not completely occlusive, but significantly reducing here the blood flow into the M2 branches. So as I said, CTA very useful in this case. And then, of course, CTA is going to help you to look for etiology. Sometimes the clots may come from the heart, patients with AFib, but sometimes the clot may come from atherosclerotic plaques. As in this case, we have an ulcerated plaque. Sometimes it may come from dissection, as you see on this case, that you see an intimal flap here on the internal carotid artery on the left with a pseudoaneurysm. We have another case of dissection here with very severe narrowing of the internal carotid artery. This patient in particular, in the context of a very poor right-sided internal carotid artery, and this patient went on and got stented in this case. Not typically we use stents in the acute setting, but sometimes we do. Moving on from CTA, from just CTA to looking at the evaluation of collaterals in a stroke, I think a very important concept to have. Let's talk a little bit now about CT perfusion imaging. Very interesting with CT perfusion imaging. I think it became very popular probably a decade ago or so. Then it fell out of favor initially when the endovascular trials came out, just because a lot of people were saying, well, CT perfusion takes a long time to acquire, and we're getting very good outcomes by just looking at the CT aspect score in the non-contrast head CT, and then looking at the CTA. But coming back, fast forwarding that to 2018, I think a lot of people are now looking into CT perfusion, especially with the newer softwares are allowing us to get the perfusion maps much quicker. And a good software right now in your CT scanner is probably going to increase the imaging time by probably 5 to 10 minutes compared to CT alone. So 5-10 minutes, not a terrible amount of time, and sometimes you get a lot of good information from CT perfusion imaging. So in terms of CTP, allows you to evaluate for cerebral ischemia, for infarction, for the vascular reserve as well. And basically, there is a linear relationship between the contrast concentration and the pixel intensity, which that allows for the quantification of blood flow values. Basically, CT perfusion relies on bolus tracking, and after you track that bolus, it relies on a very complex deconvolution algorithm. When I say complex, I mean complex mathematical equations that clearly are beyond my own understanding. And basically, what they do, this software basically generates different maps, including cerebral blood flow, cerebral blood volume, the mean transit time, and the time to peak. And with those maps in hand, you, as the imager or as the interventionalist, can then make your determination whether there is a large penumbra, if there's a mismatch between the penumbra and the core, and so on. And as I said, going back to that first cartoon that I showed, I think perfusion is the closest tool that we have to kind of like directly image the core of the infarct and the penumbra of the infarct. And here we have a typical, CT perfusion image with the different maps. Here, cerebral blood volume typically refers to the area of the core of the infarct, and then you have cerebral blood flow and the mean transit time, which typically refer to the area of oligemia or decreased perfusion, but with tissue that is still salvageable. As you can see in this particular case, you have a small core of infarct and then a large penumbra, so there's a good mismatch. I think this patient would be a candidate for revascularization, assuming the patient has a vessel occlusion. How is that penumbra maintained is a very, very, important question, has been a subject of, research as well. But basically, it has to do with the ability of the collateral vessels to provide adequate blood flow to that affected vascular territory. And the bottom line is that it varies very much between people. And, it has to do with the individual anatomy. We all have different anatomy. Some of us will have a very well-connected circle of Willis, meaning, some people have fetal posterior communicating arteries. Some people don't have any PCAMs at all. So, details like that, are what's going to determine whether the patient is going to have enough, collaterals. But the importance of collaterals that I wanted to keep in mind is that collaterals may arise at two levels. We typically know from med schools the circle of Willis that is a source of collaterals, but probably a less talked about, collateral system, but extremely important in a stroke is going to be the leptomeningeal or PL collateral. So those two collaterals, circle of Willis and leptomeningeal collaterals, are what together are going to keep the penumbra going in the context of a vessel occlusion. So talking about circle of Willis here, of course, you can see from this graph that even if you would have a complete, right ICA occlusion in this case, by injecting, contrast in the left ICA, you get full opacification of the contralateral MCA and contralateral ACA. And in fact, we know for sure that some patients can live a whole life with an occluded ICA, assuming that the intracranial vasculature, of course, is patent, because if you have a good ACAP, chances are that you're going to keep the perfusion in that right hemisphere going. And then that's in terms of the circle of Willis. In terms of the leptomeningeal collaterals, what happens is that a lot of these PL collaterals, a lot of these PL vessels have very strong anastomosis in your brain that sometimes come from the anterior cerebral artery, PL branches into middle cerebral artery. As you can see here, this is an angiogram showing the arterial phase here with a complete occlusion of the M1 segment, proximal M1 segment of the left middle cerebral artery. Yet when you look at the late arterial phase, you see that the MCA territory is actually still completely perfused. It's delayed, the perfusion, but yet it's still completely perfused because of all the good amount of collaterals that this patient has from leptomeningeal collaterals coming from anterior cerebral artery collaterals. So a very important, concept to keep in mind. Multiphasic CTA has been favored. Some good research has been done on that, including a very, seminal radiology article that came out in the last couple of years. Multiphasic CTA, basically what you do, it's similar to what we would do in other parts, such as in the liver, of the other parts of the body. But basically you look at, different phases of the CTA. You do one injection, and then you do another couple of injections in the venous and late, phases, 8 seconds apart, basically. And the whole objective of multiphasic CTA is to look at the collaterals, at those leptomeningeal collaterals that we are talking about here. So, the argument for, multiphasic CTA is that it provides you a better evaluation of that parenchymal enhancement in order for you to assess collateral. And basically, that evaluation of collaterals is an important triaging tool in determining which patients could benefit from revascularization and which patients will not. So in other words, a patient with good collaterals means that the patient can go on and have good outcomes if you were to reperfuse the patient. So, the advantages of multiphasic CTA compared to CT perfusion, basically, you do not need an additional contrast. Basically, you do use the same bolus of contrast for the initial CTA, and then you just have to repeat the scan a couple of more times in the more delayed phases, as opposed to CT perfusion, in which case you have to repeat the bolus twice, one for the CTA, one for the CT perfusion. And then another advantage, of course, is the lack of need of that additional software to do the CT perfusion maps. But, both modalities, I think multiphasic CTA, CT perfusion, good, and I think it's just going to come down to, personal preference. There hasn't been any study necessarily, comparing both of them, but I think both of them definitely useful, depending on which context, you're practicing. Moving on from CT, I think we could move now to MRI and talk a little bit about MRI. We typically use what we call in most of our institutions who deal with a stroke. We tend to have a stroke protocol for MRI, which basically focus on certain sequences that, are very relevant for a stroke. MRI, remember, MRI is the most accurate tool to determine the stroke core. With DWI, we can accurately measure what the stroke core is, so we'll have a good idea of the size of the stroke. The downside of MRI, of course, is the timing that it takes to get a sequence, probably about 4 to 5 minutes per sequence, not to take into account the fact that it usually takes time to get the checklist for MRI, to be able to scan the patient in the MRI scanner, and of course getting the MRI availability 24/7, which some centers don't have, and even if you do, taking the patient, as I said, to the MRI scanner is a little bit more of a hassle than doing it for CT. But we limit it, as I said, typically when we do need it in some situations, and I'll give a few examples later. We will use very specific sequences. Diffusion weighted imaging, which I'm sure all of us here are familiar with, is going to measure exactly what is the core of the infarct. So you see here, there's a very large infarct involving the right MCA territory. So, we can measure the penumbra. Of course, you could argue that you could measure a clinical penumbra based on the patient's presentation, but in any case, pretty sizable right MCA stroke. And as I said, a little bit more about DWI and ADC right now. They become positive right after, the stroke onset. Susceptibility sometimes is very useful in determining, the actual presence of the clot. Some people have even used susceptibility to measure the length of the clot, which sometimes have been proposed to play a role in the outcomes or in the prediction of whether a patient is going to do well or not. So susceptibility can look directly at it. And finally, MRA. Of course, we can do a 3D time of flight MRA, which is a non-contrast MRA, and kind of like do that instead of a CTA in those patients that we think should benefit from them. And in this case, we're seeing an M1 occlusion, and in this case, we're seeing a basilar occlusion using MRA. Let's go now through some cases, and I think we're going to be done very soon. I just wanted to go through some cases and kind of like in each of these examples, kind of like talk about the importance of or talk about why a specific imaging tool will be playing a very important role in those cases. Here we have a 74-year-old female with what we call a wake-up stroke, meaning the patient went to bed normal, in this case at about midnight. So she went to bed, In this case, her family knew that she went to bed normal, except that when she woke up at about 8 a.m., she had right hemiparesis and aphasia, meaning when did the stroke happen? We don't know. It happened sometime between midnight and 8 a.m. It could be 8 hours, as much as it could be half an hour. We don't know. So this is an unknown onset, but clearly in this case, less than 8 hours. This patient arrived in the ED very quickly after the symptom onset, after calling 911. Very, very high stroke scale of 24. And then we got the non-conscious HCT. As I said, typically we want this non-conscious HCT right away after this patient arrives in the ED. Here we have the first, CT, and hopefully by now you kind of remember your CT aspects. At least you have it in your head, and at least by now you kind of like could appreciate, some of the subtle changes here. Important, of course, to have always some clinical, presentation, because that, of course, is going to help you guide your eyes to the area of concern, which I'm sure a lot of you got it right here. A little bit subtle, or not so subtle necessarily, area of loss of the gray white matter differentiation here in the left frontal area. This patient got the non-conscious HCT at 8:37. Of course, not an IVTPA candidate because the onset of a stroke is unknown. Could be 8 hours, could be 6 hours. We don't know, so no TPA on this patient. This patient went on to get a CTA right away, and as you can see on the CTA, not surprised with such a high stroke scale, these patients tend to have large vessel occlusions, and in this case, where you're all seeing here the clot sitting here in the M1 segment of the left middle cerebral artery. And this patient wheeled into the interventional suite very quickly, and we punctured. We had that going puncture at 9:30 a.m. So basically, just at the hour mark of arrival into the ED. But very quickly after, interpretation of the CTA. And of course, the angiogram here, the first angiogram here showing the occlusion in the M1 segment of the left middle cerebral artery. And this is the early arterial phase, so don't be shocked that, you'll be saying by now, oh, but there are no collaterals right there, so this patient is going to do poorly. Well, it's the early arterial phase. My mistake that I didn't put any late arterial phase in this case, but the patient did have actually good collaterals in this case. And this is one pass of aspiration thrombectomy. So we put an aspiration catheter where the clot was. We aspirated and we completed the very good Tiki 3 reperfusion here. This patient did very, very well from what I remember. And as you can see here, the outcome. The day 3, the speech was normal. The stroke scale was a 0. Day 4, this patient was discharged home completely asymptomatic. And on a recent follow-up, I saw that patient actually, and he's doing fantastic. So very good outcome. Let's go through another couple of cases here. This is a 93-year-old female. So now we're getting into a slightly variation of the prior case. And I want to point out these variations because you will see that sometimes we use different imaging tools depending on how the patients are presenting. So in this case, we have, a relatively old, patient, probably not so much in South Florida where, a lot of our patients are, above 90, but probably for a lot of you, living in other areas of the country, probably 93. It's definitely on the older, side of your patients. So, this patient, typical history, presented with right-sided weakness and gaze deviation to the left, with the last known normal at 9:30 p.m. Of the day before. A very, very high stroke scale, and the CT, not done until 10:44 a.m. So clearly a patient with at least, probably 12 hours, of a stroke onset of symptoms in a very old patient. So in this case, of course, as an interventionalist, you need to be a little worried. You don't want to go overly aggressive on a case like this because you don't want to make these patients bleed. So you want to act accordingly. Maybe some subtle changes here in the CT, but overall, actually, the CT looks really, really good. If you were to give a CT aspect score, you'd probably be next to an 8, probably, maybe even 9, or maybe 8. Maybe you take 1 point out of the caudate right here, maybe another point for here. The ISO ribbon is pretty good, actually, for the most part, except for some subtle changes. So, 7 to 8 aspect score, which is pretty good. However, in this case, we're still a little worried. This patient is a little on the older side, and the onset may be, even more than 12 hours. So I think this is one of those patients that perfusion plays a very, very good role. So here we have perfusion, and here we have the cerebral blood volume showing you the core of the infarct right here. So a pretty small core, but look at the blood flow here. This is a very large area of penumbra here. Almost the entire MCA territory is still not infarcted, but at risk. That means that this patient is at risk for developing a massive MCA stroke, which the patient does not have at the moment, and this is all thanks to the perfusion that is telling us. As you can see here on the CTA reconstruction, you have an M1 occlusion here on the left side. Here we have the late arterial phase in this case showing the very large degree of collaterals, and I want to go back to those slides that I was talking about, collaterals in your brain. Here we are not surprised that this patient, despite being 93 years old, despite being probably more than 12 hours out of the occlusion, is still having a large amount of tissue that is alive, and that's all thanks to all these PL collaterals that are keeping the brain tissue alive. This patient went to have an M1 thrombectomy with complete reperfusion, and the patient did very well. This is the post thrombectomy CT. In this case, we see a little bit of contrast staining in the area where the patient had a stroke. That happens very often on post thrombectomy CTs. Don't ever be surprised, or don't never be shocked if you're reading this scan and please don't call this a bleed. It's not a bleed. It's just contrast staining in the area where the areas of stroke. Remember, this patient had a caudate and a little bit of lentiform nucleus stroke. This patient had some contrast staining, but for the most part, this patient did very, very well with, as I said, most of the MCA territory completely spared. I'm gonna go a little quicker. We have only a few more cases left, I think probably a couple only, but this patient had a 77-year-old acute onset of aphasia, right-sided weakness, 2 days following post-valve replacement. In this case, this patient had allergy to iodine. And, this case, we said, what, let's not take the risk of iodine allergy. Let's first, do an MRI. In the MRI, we see several punctate foci of a stroke, bilaterally. The patient did have some valve replacement surgery, so maybe the patient did throw a few embolic vents. But importantly, the patient does have an M1 occlusion here on the left side with not such a big stroke. So, definitely a lot of symptoms. You see the stroke scale here. You see the MRA with a complete M1 occlusion and still a good amount of tissue that's at risk because there's an M1 occlusion and there's a large amount of symptomatology here, but definitely not a stroke. So a good candidate for interventional therapy. This is another case of one pass aspiration, M1 occlusion here, complete reperfusion. Good chunk of 2 centimeter clot right there. And this is the MRI 1 day later. Definitely, you basically prevented here a large MCA infarct. And that's about it. I mean, I guess in those 3 cases, we kind of underline the utilization there of when to go with non-contrast head CT alone and clinical penumbra, when to go with CT perfusion, and when to use MRI to your benefit. So, with no more cases, I hope I'm right on time right now, and I thank you for paying attention, and I'll be glad to answer questions or talk about anything related to stroke or neurointervention or anything else you would want to ask about. It's the time to do it. Thank you very much, guys.
Thank you, Dr. Serulle, for that excellent presentation. Looks like we do have one question right here off the bat. Question is, how does the contrast staining look like on an SWI imaging?
Contrast staining, let's do that. Good question. There may be some susceptibility on SWI. I believe there are probably a couple of papers out there looking at that. But I wouldn't put much weight necessarily on the SWI, but I think definitely it will not look as blood. The flare may help you as well, and the T1 may help you in that if you're doing, post-thrombectomy MRIs, and definitely it won't bloom as much as blood. So typically, typically we get, if you do get a post, like in the case of CT, I guess the most reasonable thing to make the differentiation would be, first of all, there's no mass effect with the contrast. There is typically mass effect with, blood, and then you can always do a follow-up 6 to 8 hours later and then you'll realize that that contrast staining is gone on the CT. SWI, for the most part, I think you shouldn't see much staining. You may see a little bit of blooming, I think, but definitely not as much as you will see with true bleed. So that's the bottom line.
All right, great. Anybody else, if you have any other questions, go ahead and put them in the question box, and we'll get those answered. Serulle, I do have one question for you. You had one case there with the patient that had the contrast allergy, went to MRI. How often would you say that MRI findings change what you do as an interventionalist?
So I think MRI can allow you to, it's a very important tool, let's put it this way, and can play a fundamental role in determining whether a patient will go to intervention or not. Why so? Because if you have a patient that comes with a very high stroke scale, let's say the typical, right-sided hemiparesis and aphasia, the patient, you don't want to do, CTA because the patient's allergic to contrast, and you do an MRI and you see a large DWI lesion, then probably you want to stay away from that patient. Why? Because if the whole MCA territory has infarcted, your procedure won't have much utility anymore. And moreover, you're increasing the chances for hemorrhagic conversion. So I think in that sense, MRI answers that very, very central question in a stroke treatment, which is how big is your stroke core? In the ideal world, you would have an instantaneous MRI, let's put it that way. So sometimes that's the one thing that we would want to see. We would love to see a DWI picture on every patient, because that DWI picture will tell you if the stroke is large already or not large. Unfortunately, as I said, because of the timing issue, we don't do it, and we do it typically on admission after the patient has had the thrombectomy, and it's the time when we realize how much tissue had died before we actually recatalyzed. So going back to your question, MRI, an extremely important tool. In the ideal world, we would have a DWI on every patient, but of course, in practicality, it takes time, and because of that, it delays and the stroke care in these patients.
All right, great. Another question related to patient selection. Does infarct core volume play a role in patient management within 6 hours of onset of symptoms?
So you're asking whether infarct volume is important in patients with less than 6 hours, right?
Correct.
So, it's a very good question, because the problem with stroke is that we can't tell, hours don't mean really much in a stroke. What matters are, I hope that you guys learn from this talk, what matters are the collaterals. If you have great collaterals, you can live, up to 20 hours, you're going to still have penumbra that is salvageable. If you have terrible collaterals, sometimes 2 hours are going to be enough for you to have your whole hemisphere wiped out by the stroke. So typically, I would say that the 6-hour mark has been used as a time window in which it is assumed that most people are going to have a small infarct core. That's why in the 2015 trials, a lot of them, such as MR Clean, which was the first one that came out, they did not use perfusion. They only went by the CT aspect score. A high aspect score assumes that you have a very small infarct core. Therefore, you would be fair to proceed for intervention in such cases. So I guess in practicality, to summarize, if you have a patient with 6 hours or less, I think it is fair and reasonable to proceed without CT perfusion, without having to measure the infarct core, and then go only by the CT aspect score and the CTA. When I say CTA, I mean a confirmed LVO. I think it's very reasonable. So 6 hours, I think most patients are going to do well. I think, of course, there are exceptions. As I said, some patients have very bad collaterals, but for the most part, I think it is assumed that, the core is going to be small, and, you should proceed. That being said, some centers are doing CT perfusion on every single patient, and I don't think I would fault anyone for doing that. It's always good to have extra, amount of information.
All right, great. those are all the questions we have right now. If anybody has any, I'll give it another minute here. Again,
Sure.
I'd like to encourage everybody listening to watch for links to the future webinars coming up. We have one each week until the first week in June. Coming up next Monday, we'll be hearing from Dr. Dawn talking about the role of IR in stroke intervention. There'll be more information on that. All right, Dr. Serulle, I think that's all the questions we've got tonight. I want to thank you on behalf of the RFS, you and Kevin, for presenting tonight. I hope that everybody learned a little something.
Great. Thank you very much for having me. Take care, guys.